inflammatory, they will also secrete things like reactive oxygen species, which we know are very destructive. If we can think back from the cardiology lectures, and in terms of reactive oxygen species, the dismutase, which normally which normally denatures the reactive oxygen species and actually causes them to decompose quickly, does not work. So the dismutase does not work because of the ongoing inflammation and ongoing pathogenesis. So we will have increased oxygen species as well. So the IL-8, going back to IL-8, the IL-8 and other cytokines will recruit CD. Did I read this? Will recruit. Let me try a different pen. Will recruit CD8 positive T helper cells. And when these cells are recruited, they mediate a cell-mediated immune response. The IL-8 will also recruit neutrophils. So now we'll have the CD8 mediated, obviously, secreting IL-8 as well, and IL-12, all of which eventually lead to the recruitment of neutrophils. And neutrophils have inside them granules, and these granules have things like proteases, which trypsinize things. They also have they have a lot of denaturing enzymes that just attack proteins and tissues as part of the inflammatory response. Because if we were to think about it, this is a response to smoking. It's not really a response to a pathogen that we can extract or isolate and say, okay, there is a pathogen, because this is just a response to smoking. And another thing to remember with inflammation is that while this chronic inflammation, this chronic picture of inflammation happens, there is also the acute phase inflammation. So there is acute phase inflammation as well. And this job really is to sustain the chronic inflammation phase. So you end up with a vicious circle of constant inflammation. And as that inflammation is occurring, what happens is you will then have the activation of fibrosis. It will come from I forgot the name of the cell. Well, the fibrosis will occur with chronic inflammation. So chronic inflammation will eventually lead to fibrosis and narrowing of airways. They will also be squamous cell metaplasia, because if we look at, if normal small airways actually have columnar epithelium, epithelium. So, but with chronic inflammation, there is remodeling, and we end up with squamous cell metaplasia. There is also, you know, a lot of growth tissue factors and growth factors which sustain fibrosis as well. So you end up with a remodeled narrow airway. So if this was a normal airway which had columnar epithelia and it had its elasticity as well, it should be able to constrict and relax, to allow for, you know, gaseous exchange to occur, and to allow one to take in air. However, when so it has a small wall, you know, that allows for gaseous exchange to occur. However, in chronic bronchitis, which when there is remodeling and fibrosis and hyper secretion of mucus, you end up with an airway that has a lumen that's usually reduced, that then is a large these are, you know, these squamous cells are actually there, and this is a large hypertrophied wall. So this is a large fibrosed wall that has lost its elasticity, so it cannot constrict and relax as well as it should. So this is a fibrosed wall. I think I'm running out of pens. Fibrosed wall with reduced elasticity. And then you have a large goblet cell there producing a lot of mucus. So this is a lot of mucus being produced, coming in to line the airways and absolutely restricting, you know, the passage of air. So you end up with, so this, obviously this will not have one, we'll have like masses, whereas normally you probably will have that many goblet cells, you know, and they are that little, but here they become hypertrophied. And then there is also loss of elasticity, and I've already mentioned fibrosis of the wall. So this is the picture that you know, we have in chronic bronchitis. Obviously this is the bronchi, you know, before we actually get into the alveolar. And I must say this is the large bronchi, not the pulmonary bronchi. So then now we've seen how inflammation occurs and how we end up with a lot of mucus production that can become purulent as well if there is a pathogen in there, if it becomes infected with a pathogen. So then we'll quickly look at emphysema. Emphysema is basically defined as the loss of elasticity like shall I say elastic recoil of the distal airway, as in distal to the terminal bronchi. So distal to terminal bronchial. And this loss of elastic recoil then leads to airway trapping. Well, it leads to an airway that can collapse, and it also leads to an airway that, you know, when you lose the recall, you also lose, and there is also the destruction of the ridges in the alveolar, and the destruction leads to an enlarged alveolar that has no septa that actually ridges and ducts. So the destruction is an enlarged alveolar with no ducts or separating septa, and that leads to airway trapping. So airway trapping results from that. So emphysema is actually classed into two different types. We have, like, if we were to go back to what an alveoli look like, I need pens, new pens. An alveolar look like something like that. So if this was our alveolar, oh dear. And if we were to remember, I'm trying to draw this ever so quickly. So it will have an alveolar duct there, and there will be these ridges or walls between each alveolar that define, you know, a well-defined alveolar tree, because it really looks like a bunch of grapes. So this is our terminal bronchi there. Bronchiole, bronchiole. And these here are called the pulmonary bronchioles. So we'll call these the pulmonary bronchioles. And then this is the alveolar duct. And obviously the alveolar sac, and one of these is an alveoli. I always feel the need to do that, just to remind myself of the names of these things. And the distal, the pulmonary bronchioles and the alveoli are housed in an acina. And so emphysema, the destruction in emphysema can happen here. Let's find a different pen altogether. If the destruction is here, where, you know, where the alveolar ducts and sacs are preserved, we call this the central emphysema. So it actually spares, and the way, you know, its characteristic is that it actually spares the alveolar sacs, and ducts. So this is the most common occurring type of emphysema. So this is the common type of emphysema. The other type of emphysema that we have is one that is called the pan-ancina emphysema. So pan C. acinus emphysema, which is not very common. So the pan-acinus emphysema, it's not very common. And when we say pan, obviously pan means the entire thing from the terminal